Right. But, so the.
Hello and welcome to today's symposium sponsored by Lymphatic Education and Research Network. I'm Bill Rapisi, Executive Director here at LE&RN. Today's symposium blesses us with two speakers of great note in the field of lymphatics and lymphedema. Dr. David Chang will speak on microsurgical treatment of lymphedema, and Dr. Jessica Kandel will speak on new clues to understanding lymphatic disorders in children. Before jumping into the symposium, I can report that it has been an extraordinary month for LE&RN and for those that support our efforts. In March, the New York State Assembly and Senate both passed resolutions recognizing March 6th as National Lymphedema Awareness Day. Along with this, they passed resolutions recognizing 7-year-old Connor Luby for his work as LE&RN's youth ambassador. Connor then sponsored a fundraiser for LE&RN the next day. This all helps to bring awareness of lymphatic disease and lymphedema to lawmakers who are in a powerful position to positively impact our field. This has led to consideration of both a funding bill for LE&RN's patient registry and tissue bank, as well as reconsideration of an insurance bill that would address lymphedema needs here in the state. Insurance needs. LE&RN also recently received a $500,000 bequest. This bequest came from Dorothea Weitzner, who passed away earlier this year. This bequest inaugurates the Weitzner Family Fund to support research fellowships that address lymphedema. Ms. Weitzner's brother suffered from lymphedema throughout his life, and this was her way of honoring his struggle and to give tribute to her parents as well. Also, LE&RN has announced 2 new 2-year research fellowships have been awarded. Dr. Mikey Fry at the University of Uppsala in Sweden has been awarded the first Weitzner Family Fellowship. The second fellowship is going to a researcher at the Institute of Molecular Bioscience at the University of Queensland, Australia, who will receive the fellowship for her work, which is also in the area of lymphatics and lymphedema. You can find out more about these on our website at lymphaticnetwork.org. Finally, in March, LE&RN attended the International Gordon Research Conference in Lymphatics. In keeping with LE&RN's dedication to bringing the best and the brightest new researchers into the field, 10 young investigators attended, thanks to $1,000 grants provided by LE&RN to defray costs and registration costs. Turning to today's symposium, we are delighted to welcome back our friend Dr. David Chang and to introduce our first live stream featuring Dr. Jessica Kandel. Dr. Chang is a skilled plastic surgeon specializing in reconstructive surgery in cancer patients. His specific interest and expertise has been treatment of lymphedema, where he has pioneered techniques that you'll hear more about today. He is a professor of surgery at the University of Chicago Medicine and Biological Sciences. Dr. Jessica Kandel is the surgeon-in-chief at the University of Chicago Medicine Comer Children's Hospital, professor of surgery and the vice chair of Pediatric Surgical Services. She co-founded the Columbia University Vascular Anomalies Group in 1998, which became a leading resource in the New York City area. Upon her recruitment to the University of Chicago in 2013, she organized the Vascular Anomalies Group at that institution. Without further ado, we very much welcome Dr. Jessica Kandel and Dr. David Chang. I turn it over to you at University of Chicago. Thanks very much all.
Okay, good afternoon. It's a real pleasure to be here today. So today I'd like to share with you current techniques and approaches to lymphedema surgery. As you all know, lymphedema occurs due to a failure of the lymphatic system. The causes can be divided into primary lymphedema, which occurs due to a condition that's inherited with some type of a problem with lymphatic vessels or lymph nodes. It can occur in infancy, it can occur in childhood, or even in adult. The more common causes are secondary, often either due to removal of lymph nodes due to a surgery involving some sort of a cancer treatment or radiation to the lymphatic area. The parasite is also a very common cause of lymphedema. In fact, worldwide, it is the most common cause of lymphedema, and filariasis is the parasite that goes into your lymphatic system and causes obstruction of the lymphatic system. Lymphedema can occur in patients where lymph nodes are removed and radiated. Oftentimes this happens in patients with breast cancer patients, and it is estimated that up to 5 million Americans suffer from lymphedema, and about 50,000 new cases are being diagnosed annually. It is a debilitating problem. Those who are affected by it are well aware of this, and currently there is no definitive treatment, and it is poorly understood. So what do we currently know about lymphatic system and lymphedema? Well, lymphatic system is similar to our rest of the vascular system in that there are lymphatic capillaries that are located under the skin, and they drain to the lymphatic vessels, which are located in the subcutaneous tissue and also in a deeper tissue. They eventually drain into the venous system in the right and left side of the neck. Lymphatic fluid drain by contraction of the surrounding muscles, but there are also smooth muscle cells that are located within the lymphatic vessel that will contract and help with the lymphatic drainage. This is a cross-section of the lymphatic vessel that we're looking under the microscope, and what we see is that it has 3 layers like other blood vessels such as artery and the vein, and there are smooth muscle cells that are located within the tunica media and also at the outer layer. This is a lymphatic vessel in a patient with lymphedema, and you can see that the lumen of the lymphatic vessel is almost all occluded. This is in the proximal limb, and this is more distal, and the smooth muscles that are located in these layers has undergone atrophy. So the lymphatic vessels itself has undergone some significant destruction and change. In many patients, lymphedema can be progressive and can lead to a irreversible damage to the tissues, such as interstitial fibrosis and atrophy of the smooth muscle cells that are contracting, that are supposed to contract within the lymphatic vessels. So the lymphatic vessels no longer become a dynamic vessel, but can become a static tube, oftentimes with the lumen that is already occluded. So current surgical treatment can be divided into excisional procedure or physiologic procedures. Excisional procedure, one example is known as a Child's procedure, where you resect the tissue down to the fascia, and then you skin graft the site where the lymphatic, you skin graft the area where the tissue has been removed. Another excisional procedure is a liposuction, and it can be very effective in reducing the lymphedema, but the patient has to wear the compression continuously for the remainder of our life. Otherwise, after 2 or 3 days, the fluid will start to recumulate and lymphedema will recur. Physiologic procedures involve microsurgical techniques. Here we try to bypass the area of the lymphatic damage or obstruction, or try to reestablish lymphatic function at the site of the injury. One such procedure is a lymphovenous procedure. Here we are creating a detour or a bypass of obstructed lymphatic system into open venous system, so that the lymphatic fluid can escape into a venous system prior to the obstruction. The first such procedure was described by Jacobson in 1962 in a dog model. The approach that we currently use is largely a variation of what was first described in year 2000 using what we call super microsurgical technique, where very small lymphatic vessels are connected to very small veins. The theory here is that the venous pressure at this level is very low, so there is a minimal dermal backflow. As you can imagine, when you're trying to bypass one system to the other, if the outer system has a higher pressure, then the fluid would not drain to that system. So it is important that the venous pressure must be low in order for the lymphatic fluid to be able to drain into that system. So I started doing this procedure in 2006 and have since published 2 papers on my personal experience, and the most recent one was in 2013 November, and reported that in on average at 12 months 42% reduction in excess volume was noted by the patients. And one of the advances of current lymphatic surgery is our ability to visualize the lymphatic system before the surgery is done. So here is a dye called indocyanine green, which is commonly used dye that is injected into the skin and is uptaken by the lymphatic system, and you can visualize the flow of the lymphatics in the lymphatic system. As you can see here, this is a demonstration done in a person who has a normal arm. So on the left side is the arm that does not have lymphedema, and this is a patient with lymphedema, and you can see the little bit of difference here. There is this is called the dermal backflow. There's a dilated lymphatic capillaries, and there is no good visualization of lymphatic vessels here. And by looking at this ahead of time, I'm able to mark out the sites for the best location for the bypass, and also we can evaluate how severe the lymphedema is in each patient. Here's a short clip of video showing how lymphovenous bypass can be done. This is a videotape under the microscope. Here's a lymphatic vessel that's been identified, and it is a clear tube, as you can see there, and then we will need to find a vein nearby where we can bypass to. And this just been edited and fast forward with a lymphatic. This is a venous a branch of a vein, and this is a lymphatic, and then we are going to be we'll connect them together under the microscope with a fine sutures so that the lymphovenous bypass is performed. And the way we can tell that the lymphatic fluid is draining into the vein is one way is to use the same indocyanine green technology to visualize the green dye go from lymphatic system through the anastomosis into the vein. Another way is to inject blue dye, which goes into the lymphatic system through the anastomosis into the vein. And what I found in my experience is that the patients who do well from LV lymphovenous bypass are those patients with a milder form of lymphedema with minimal chronic or irreversible tissue damage. Once the lymphedema becomes very severe and there are very few lymphatics that are functioning, then the lymphovenous bypass does not appear to be as effective. This is a patient with a 5-year lymphedema of her left arm, 32% larger than her right arm. This is the indocyanine green lymphangiography of her arm, and you can see the streaks of the lymphatic vessels going through here. And I did 5 bypasses on her, and this is at 15 months. Her arm is now down to 12.6%. There was 60% reduction in the volume differential. This is a patient with a left arm lymphedema for a year and a half. Her left arm is about 18% larger than her right arm. And here the indocyanine green shows very few lymphatic vessels. There's one here, there's one here, and probably some on the other side. Did 7 bypasses. Although she felt the arm was better and softer and lighter, when we measured the difference was minimal. Another approach that's been very popular, particularly over the past few years, is vascularized lymph node transfer. This was described in 1970s, and also this is an example of a study in a animal model 1990 demonstrating the effectiveness of lymph node transfer. There's some clinical papers, mostly from Asia and Europe, in patients where it's been demonstrated to be an effective way of treating lymphedema. The way vascular lymph node transfer works, there are two schools of thought. One thought is that the transfer lymph nodes will suck the excess fluid into the lymph nodes and then bypass it into the venous system. And another school of thought is that the transfer vascular lymph nodes will promote lymphangiogenesis and then reestablish lymphatic function. Now, the groin is a common area where the lymph nodes have been harvested. The one thing we have to be careful is when we take lymph nodes from the arm, from the axilla or groin, is that we do not sacrifice the important lymph nodes that drain that extremity so that the secondary lymphedema does not occur. And this is a study demonstrating how in 13 patients, even though patients did not develop clinical lymphedema, when the lymph nodes were harvested from the groin area, the lymphatic function decreased when lymphatic function was measured by lymphoscintigraphy. And another study showing that some of the patients did develop chronic lymphedema. And these both studies are from Europe. So the lymph node transfer that I have used most commonly is from the neck, because I feel this does not have any secondary does not cause a secondary lymphedema to the arm and leg. And this is a patient with left arm lymphedema following mastectomy and radiation. As you can see, the indocyanine green demonstrating a lot of dermal backflow, dilated lymphatic capillaries with very few lymphatic vessels. So this is her axilla. She had a breast reconstruction done elsewhere. We open up the axilla, take all the scar tissues out, then take a tissue from her right side of the neck, and then transfer into the axilla and connect the blood vessels so that it is a living tissue, so that it will start to regenerate lymphatic vessels. And this is 1 year later. The arm has had a significant reduction. Patient with the primary lymphedema of her left leg. Here too, again, take lymph nodes from her neck and we transfer down to her ankle, and this is about 1 year following the surgery. The leg is not normal, but it's gone down significantly since time of surgery, prior to surgery. Another example of a very severe lymphedema with lymph nodes transferred to his ankle, and the leg is about 30% smaller than before. Another way we have been using lymph node transfer is to combine with the abdominal tissue to do simultaneous breast reconstruction and to treat lymphedema. As a lot of patients who present to me have had a mastectomy, radiation, developed lymphedema, so they are in need of both breast reconstruction and something to done for her lymphedema. And this is how here's a cartoon demonstrating how surgery is done. We take abdominal tissue based on the vessels. These vessels will give blood supply to the skin and the fat. And here's a lymph node with its own blood supply. And then this tissue is detached and transplanted to the side of the chest, mastectomy. And then the vessels are connected, so these are living tissues with its own blood supply. The lymph nodes are put into the axilla. So this patient has about 49% lymphedema of her right arm over left arm. And what I do when I take lymph nodes from the groin is I inject technetium-99 into the foot of the leg that I'm going to be taking lymph nodes, and then using a device in the OR, identify the critical lymph nodes that drain the leg, and those lymph nodes are preserved and not taken, so that the leg drainage is preserved. So here the abdominal tissue is taken with lymph nodes from the groin, and this is a blood vessel, what's called a DIP flap for the breast, and then simultaneous breast reconstruction is done. The lymph nodes are placed in the axilla, and patient now has a 51% reduction in volume differential. So this is a presentation that we did in our annual meeting in November last year of 24 consecutive patients, and there was about 47% mean reduction in volume differential at 12 months. I think we have now about 50 cases altogether. So does the lymphedema surgery work? Debulking procedure does work, but morbidity is severe. Liposuction can be effective. However, patient has to be committed to wearing the compression garment for the remainder of life. Lymphovenous bypass, I think it's best in upper extremity for patient with a milder lymphedema. Vascular lymph node transfer, I think it is an effective tool. We have to be careful of causing secondary lymphedema. So in summary, microsurgical treatment of lymphedema, in most cases, it does not cure lymphedema. It does improve severity of lymphedema in most cases. It does reduce the complications related to lymphedema, such as infection. And in most cases, it does improve patients' quality of life. Currently, there's no optimal solution. There's a lot of research being done, exciting research being done. One of them, Dr. Kandel will share with us today. But we need a better understanding of lymphatic anatomy, physiology, and pathophysiology. This is a final example of a patient with severe lymphedema following radical hysterectomy and radiation. And of course, none of this procedure, really microsurgical procedure at this point, is too late. But the question is, could this have been avoided if she had an earlier surgical intervention? So we debulked the tissue, and then we skin grafted it. The leg is not, it's not normal looking, but compared to before, it is much improved, and it allows her to able to now wear normal pants, able to ambulate, hike with her husband, go back and start working, and wear normal shoes. So for her, there has been a significant improvement in her quality of life. Thank you. And now Dr. Kandel will share with her about her experience.
Thank you very much, David. I'm going to be talking about new clues to understanding lymphatic disorders in children. I'm not able to make it advance. And during this talk, I'm going to be discussing the off-label uses of some FDA-approved agents for treatment of children with lymphatic anomalies, including propranolol. And I want to mention that all the patient photographs in this presentation were obtained and are shown by consent. So the lymphatic disorders in children are different from those we saw in the previous talk by Dr. Chang. What are lymphatic disorders in children? Well, mostly they're congenital errors in development of the lymphatic part of the vascular system. And these include lymphatic malformations, congenital lymphedema, and congenital accumulations of lymph fluid, such as ascites or lymph fluid collecting in the abdomen, or pleural effusions, lymph fluid collecting in the chests. Almost nothing is known of their pathobiology. Which of these lymphatic disorders are clinically important? And for pediatric general surgeons, we would say those which are exerting systemic effects on children, which affect their ability to engage in the activities of daily living. For example, lymphatic disorders can have a mass effect. They can take up so much tissue space that they interfere with the function of other body systems. They can block what's called your aerodigestive tract, the breathing tube, which is your trachea, or the swallowing tube, which is your esophagus. And they can have so much mass that they interfere with vision. They can also cause derangement of the circulation of the lymph, that incredibly important rescue of fluid from the tissues and its return to the venous system that Dr. Chang showed you in his talk. When that circulation is deranged, you get stasis or failure to move of lymphatic fluid, which causes swelling or fluid accumulation. In children, this can cause coagulopathy or disorders of the clotting mechanism, and superinfection, which is simply the increased likelihood that a pool of lymph fluid is going to be infected because it doesn't move back to the central circulation. Children who have lymphatic disorders that affect the face and neck are one group that is very significantly affected by these. These disorders are increasingly observed on antenatal studies, ultrasounds done for expectant families, and these will raise questions of how to manage the baby's airway during delivery if it's shown that the lymphatic mass is compressing the airway. A baby in this case may need to be delivered with special support, such as that offered by the exit procedure, ex utero intrapartum treatment. And this is delivery on placental support, so with the baby still connected to the circulation of the mother, with extracorporeal membrane oxygenase in standby until the baby can have a new airway developed. And this is an example of a baby that had a compromised airway. The circular white structures in the baby's jaw area are lymphatic malformation. And this study was done at 38 weeks of gestation before the baby was born. And when this child was delivered, the baby almost immediately needed to have a tracheostomy done, a surgical access placed into the airway so that the baby could breathe. This is a child who has a different manifestation of a lymphatic disorder, what we would call stasis, or the failure of lymphatic fluid to move normally. The spongy white areas you can see in this MRI are areas where abnormal lymphatic tissue is involving the tissues of the child. And because lymphatic fluid in this area doesn't drain normally, it's very prone to infection. And this child has required numerous procedures for this infection. How can we improve the current management for these children? Well, the first question that we asked ourselves was whether we understood the biology well enough to offer better answers, and the answer was, of course, we didn't. So one of the ways that we can improve our understanding of the biology for children is to look into other experimental systems and see if they'll offer us clues. And very valuably, transgenic mice have recently been developed that mimic human lymphatic malformations. This particular mouse was developed by a colleague of mine in the laboratory, Dr. Schauber, and what she found is that activating a member of the Notch family pathway disorders the formation of normal lymphatics in baby mice so that they get swollen necks, similar to the children with cervicofacial malformations. She also found that this went along with failure to differentiate, to mature, of forming lymphatics, so that they failed to express the normal markers of mature lymphatics, which here are protoplanin and PROX1. When we went back to look at our bank of stored tissues from children with lymphatic anomalies, we found out the same pattern applied. Notch was improperly activated in the involved tissues from these patients, and markers of lymphatic identity were co-expressed with Notch, showing us that it was indeed the lymphatic tissues which had improperly differentiated. After we had this information, we were able to go back to our tissue bank and characterize two types of cells from lymphatic malformations. One set of cells were more like progenitor cells. They were more stem-like. They were less differentiated. And another set of cells were like the lining of endothelial vessels that comprise lymphatics. And then we studied these cells and their responsiveness to an array of drug treatments using an automated microscopy system that can allow us to very precisely measure the ability of cells to withstand drug treatment. And we also found out that these cells could be reimplanted into mice and would recapitulate, reform lesions like the ones that they had come from in children. And in the bottom 3 panels, you can see erratic spaces that are formed by these purified cells. And this model allows us to study treatment options in an animal setting before we would need to apply them in children. And one example of being able to test drug action in these purified cells is the response that we see here to propranolol. We took lymphatic malformation cells and tested them against a solution of this drug, which is a very old, very well-established beta blocker that has been used to treat children for about 40 years for other causes, and found, somewhat to our surprise, that the lymphatic malformation cells were extremely sensitive to it. They could not grow in the presence of this drug almost at all. And then we used these results to offer new options to patients who were very, very severely affected by their lymphatic anomalies. For example, this child with the pelvic lymphatic anomaly was in the hospital many times a year with uncontrolled bleeding and infection from his anomaly. And when we discussed our laboratory results with his parents, they sought to take advantage of this potential new insight. As a first step, we treated his involved skin with a gel that contained a beta blocker and noticed that the lesions on the skin healed. The parents then asked to begin oral propranolol, which we did. And they informed us that they noted that his lesion was shrinking with healing of the eruptions, and 2 weeks later he was able to walk and was no longer wheelchair bound. And that was really a very exciting follow-up to these initial studies. At about the same time, we were referred a baby with a lymphatic malformation who was about 33 weeks gestation, still in utero. And the parents were referred to us to discuss the options for delivery should the baby's airway still be compromised at that time. And among the other options we discussed with the parents was propranolol. Fortunately, propranolol has been used in the 3rd trimester of pregnancy for many years by maternal fetal medicine experts for control of other conditions in the fetus. And this family elected to start that therapy. And we were able to follow the baby by MRI and found that the airway was stabilized so that the baby grew and the mass did not, and the airway was opened. And at the time of delivery, we again checked with ultrasound, showed that the airway was open and not obstructed. The baby was delivered uneventfully with APGAR scores of 9 and 9 and no respiratory or feeding issues. We made the decision in consultation with the baby's family to maintain her on propranolol and to monitor her lesion, and she's done very well since then. This is another patient. This is a 19-year-old man who had a lifelong history of bilateral lower extremity swelling due to lymphedema and ascites, collection of lymph fluid in the abdomen. And he was transferred to our pediatric intensive care unit after developing an infection from a surgical procedure that had been done to debulk his malformation. We helped him recover from his infection, which involved doing some drainage procedures on affected parts of his body. And what we found was that the fluid from the affected parts of his body contained lymphatic progenitor cells similar to our earlier studies, and that these expressed the beta adrenergic receptors that are the target of propranolol and other beta blockers. The patient elected to begin propranolol. He was an adult, so could make that decision for himself. and a month later was 5 kilograms or more than 10 pounds below his baseline weight, and bought new clothing because his swelling was much improved. And this was also a very exciting result. So in summary, we think that patients with lymphatic disorders can really benefit from a multidisciplinary and translational approach, as I've outlined here. Our biologic understanding is really just beginning to emerge, and even at this early stage has revealed new targets to us for treatment. Our armamentarium, that is the backpack of methods that we have to treat patients, is constantly evolving, and it's likely to include new methods of imaging, of surgery, ablation, and drug treatment, as I've described here, what we call multimodal developmental therapeutics. I'd like to thank the colleagues who have helped me with this work and to acknowledge our funding sources. Thank you very much. Okay. Pull up this chair. You got it? Hello, Phyllis. I see that you're asking, is there a difference between lymphedema and lymphangioma and lymphatic malformation? My answer to that would be, we think so because they look different, and they're likely to be the result of different errors in developmental pathways, but really defining these differences and figuring out what they'll mean for treatment differences is something that we're still doing. And thank you, Laura. I see your question is, how can parents get answers about a child's lymphatic disorder? I think a really good resource for parents are the vascular anomalies treatment groups that are available in children's hospitals more widely across the country. We have one here at the University of Chicago, but there are others to be found, and one of the sources obviously to contact is a Lymphatic Research Foundation that can help families identify those children's centers. There's a question from Stacy asking, what are the risks to treatment with propranolol? So propranolol is a very, very old drug. We've been using it in hospitals and on outpatients for about 40 years. So of course there's a very long list of potential adverse effects. In children, it appears in general to be a very safe drug. It can slow the heart rate. It can make children feel dizzy. In very little babies, it can reduce the blood sugar if the babies don't eat often. So we do ask our pediatric cardiology colleagues to screen patients before we start propranolol and to help us monitor children when we begin this treatment so that it's as safe as possible. So Phyllis, thank you, has asked, at what age can a child undergo imaging techniques, lymphoscintigraphy, etc.? Any issues with dye injection or making the condition worse? So I can answer part of this, and I think Dr. Chang will answer part of it. So I don't have tremendous personal experience with lymphoscintigraphy. In general, we're quite conservative with imaging. And we'll generally begin with ultrasounds for children. And then if we think it will be useful for guiding therapy, we'll obtain an MRI. With very little children, that can sometimes require sedation or anesthesia. So we're thoughtful about how we ask for that kind of test.
Yes, I don't have a lot of experience with the lymphoscintigraphy in kids. so I don't know if I can adequately answer that. In terms of using like indocyanine green, I think those are okay. Indocyanine green is commonly used in surgery. In terms of if I think the youngest one I've done lymphoscintigraphy for diagnostic purpose was perhaps like 14 years old, and it was a large teenager. So if they're 3, 4, 5 years old, I really don't have experience with those children of that age. I would have to defer that to our nuclear medicine colleagues.
I'm acknowledging a question about whether propranolol is only effective with malformations. Is it on its own helpful in Milroy's management? I really don't know the answer to this. It's a very, very good question. And I hope as our experience with this therapy grows, that we'll have more precise answers for you. Question from Adrienne. Could adults with congenital lymphedema benefit from propranolol? That's a very good question. And again, I don't know the answer to it because I, in general, treat children, and so I don't have a bank of experience in treating adults with propranolol, but it's a very, very good question. I think it's a reasonable question for an adult with congenital lymphedema to raise with their caregivers to see if it would be something safe to try for them.
Yeah, this is something that we are working together on, and there are a couple of patients we are going to see if it will be effective or not. And if it can be, I think it would be a great another way to manage these patients in addition to surgery, either together or just with medication alone. Okay, Colleen McGuire, what makes someone a good candidate for lymphatic bypass? So, at least in my experience, what I find, the patients who are best candidates for lymphatic bypass are for upper extremity with the milder form of lymphedema. When I say milder, it's when I do indocyanine lymphangiography, I can find several good lymphatic vessels, and there's some dermal backflow, but not so severe. So you can do lymphatic bypass on lower extremities or in more severe forms as well, but by itself, I think the results probably would not be as good. What I've been doing more lately over the past year or two is combining them with the vascular lymph node transfer for this type of patients, so that they can perhaps get benefit from both procedures.
Looks like that's the end of our questions today. Thank you very much for allowing us to deliver this information. We enjoyed talking to you.
Thank you very much.